Okay. Hi, everyone. Thank you so much for joining us for this virtual event and this important conversation on critical healthcare disparities during COVID-19. We're joined by an excellent cast of leaders and medical experts from our community. So I'm really looking forward to the conversation that we'll have today. On behalf of the Chamber, we hope you are joining us today feeling safe and healthy. This series is part of our economic opportunity efforts at the Boston Chamber. My name is Bea Jimenez. I'm the new Director of Economic Opportunity. And as news about COVID-19 continues to evolve, we're here today to discuss inequities that can emerge during crises, efforts underway to mitigate the impact of the pandemic, and how we can collectively support our region's communities that are disproportionately affected by COVID-19. We're committed to developing and implementing a response that is united so that everyone in Greater Boston has equal opportunity and access for all. Before we get started, I also want to thank some really critical partners of ours, BECMA and Amplify Latinx. Thank you so much for your leadership during this time, and we're extremely appreciative of our continued partnership with you all. I want to also flag that this webinar is being recorded and will be shared on the Chamber's YouTube page shortly after the presentation. Each of you will also have an opportunity to submit your questions using the chat feature that's right below your screen. You can also email us questions throughout the event to chamberprograms@bostonchamber.com. So you have two ways of submitting questions today. You can do so through the chat feature, or you can email us at chamberprograms@bostonchamber.com. I want to also make sure before we begin this conversation on something that we know is affecting many people very deeply today, perhaps one of you on the call or even a family member or anyone that might be experiencing issues. We want to make sure that today's conversation is one that we have with compassion and empathy. And we want to make sure that we think about that as we go over some numbers that might be very difficult to process. So I just want to make sure that we uplift that as well. So I want to introduce our special guest for today. We have Dr. James. Hi, Dr. James.
Hi.
Vice President of Mission and Associate Chief Medical Officer at Boston Medical Center.
Hello.
Dr. James is an Associate Professor of Emergency Medicine and Director of the Violence Intervention Advocacy Program at Boston Medical. She works with caregivers throughout BMC and has the primary responsibility of coordinating and maximizing BMC's relationships and strategic alliances with a wide range of local, state, and national organizations, including community agencies. Dr. James was appointed by Mayor Walsh to the city's Health Inequities Task Force. I'm also pleased to introduce Stan McLaren. Hi, Stan. Stan is President and CEO of Harvard Street Neighborhood Health Center. Stan works to eliminate social disparities among immigrants and people of color. Stan serves on the board of the Steward Healthcare Network, ACO, the board of the Carney Hospital, and the New England Council's Healthcare Committee. We're so pleased to have you, Stan.
Thank you.
Last but not least is Michelle Corton-Brown. Hi, Michelle.
Hi.
Michelle is the CEO of Quality Interactions, a company dedicated to training solutions for healthcare professionals to better communicate with and care for diverse patient populations to reduce health disparities and improve patient experience, health outcomes, and financial results. Michelle is a board chair of Health Resources in Action, a public health institute, and she was also appointed by Mayor Walsh to the city's COVID-19 Health Inequities Task Force, and Quality Interactions is a minority business enterprise in the Chamber's Pacesetters initiative. Thank you all for joining us today. I want to start with some opening remarks from each of you. So we'll start with Stan, then we'll go to Dr. James, and then we'll go to Michelle.
So my name is Stan McLaren. I'd like to first thank the Boston Chamber of Commerce and Bea for inviting my esteemed panelists and me to present on such an important topic. I'd like to also thank those of you who are tuning in. I can't really start with my comments without saying something first, that I'm a man of faith who happens to be a CEO of Harvard Street Neighborhood Health Center. I live 5 minutes from my health center. My background is in accounting and financing. And I've been led to be in the healthcare because of the love for my neighbors. My health center is located in Dorchester, near the heart of the Grove Hall area. We serve some of the most economically disadvantaged zip codes in Boston. We are a comprehensive health center, and we have been a trusted partner in providing convenient quality care in the community for 51 years. That said, no one on this panel or in public health is surprised by how this disease is impacting the Black and brown communities. Although this disease hits indiscriminately, the pace at which African Americans are dying, we think has transformed this public health crisis into a lesson in racial and class inequality. In this conversation, we'll try to provide some historical context for policies that have led to structural inequalities in access to healthcare and economic opportunity. COVID-19 is laying bare the bitter harvest of structural racism in the United States. A history of systemic discrimination has made many African Americans far more vulnerable to the virus. So the current disparities with regard to this disease is no surprise. However, I genuinely, and I really do believe that this is a we disease. I'll repeat, this is a we disease. And I say that to say that the only way we get through this is together. I don't know if many of you know this, but community health centers began during the Civil Rights Movement and are rooted in the fight for social justice and equality. Health centers are in every community in the country, both rural and urban, and we are vested in improving access to care for vulnerable populations. We're among America's first responders. My health center cares for medically underserved regardless of ability to pay. We predominantly serve working class people of color, 70% of who live below the poverty line. They're individuals who live in housing with multiple family members, individuals who don't have the luxury of working from home and have to take public transportation to get to work. For the most part, they're working in jobs which are now considered essential services, which consistently puts them, an already vulnerable population, in harm's way. Many of our patients present with comorbidities. Typically, if you are struggling financially, you're also struggling with your health. As a matter of fact, we have seen a dramatic increase in individuals and families contacting us for additional food through our food pantry. That's food piece is really having a dramatic effect on the clients we serve. They have underlying conditions like heart disease, asthma, and diabetes. These underlying conditions create higher risk for severe illnesses from the coronavirus. We've been testing for the virus for over a month now, and I really need to give a special shout out here. I think the mayor's office has done an excellent job. The Matthew Community Health Centers, MEMA, and our state and local health departments have been excellent in providing information and advocating for resources and providing technical assistance in helping us to stand up our testing. As a matter of fact, last week, the mayor's administration provided funding through the Boston Resiliency Fund to help health centers and other community-based organizations that deal with vulnerable populations in Boston to increase our capacity for testing. Given the severity of this pandemic, these supports are very important as it allows agencies like mine to focus on our patients. About 40% of those that we have tested so far have tested positive for this disease, which for me is scary because Black people make up 14% of the population in the United States and 33% of those who have died from the disease. As a community health center leader, I'm not only on the front lines of our fight against this disease, but I'm in the front row witnessing the results of systemic policies that have promoted social and environmental racism, that have erected barriers to economic and has erected barriers to economic development for Black people. I'm hopeful that the devastation this disease is having in my community will be a catalyst for a sustained and focused change, and that we won't go back to business as usual. As business leaders and individuals, you should begin to imagine how and where you can fit in that change. Thank you.
Thank you so much. Dr. James?
Good afternoon, everyone. I also would like to thank the Boston Chamber of Commerce and BEA and today's attendees for, on the webinar. It is actually a privilege to be able to spend this time with you today. So I grew up in the Washington, D.C. area, where the federal government was and actually remains to be an anchor for that area, Maryland, D.C., and Virginia. And so I'm saying that to say that I grew up seeing people thriving. It's not that there was no poverty there, and during that time there was some poverty, but a majority of the people I saw who happened to be people of color, African Americans, it was about 80% African American when I was growing up, DC was. I was just accustomed to seeing people thriving. And then when I graduated from medical school, I came to Boston to do my residency in emergency medicine. And when I got here, I saw something that was quite different. And it was good for me, actually. I think it has helped me to evolve and to see some pathways forward in terms of shifting paradigms, in terms of healthcare for specific outcomes. But what I would see in the emergency department was repeatedly people coming in with the exact same problems. So they would come in with some unstable medical issue. We would, usually fix them, for lack of a better word. We would fix them and you discharge them, but then they would come back over and over and over again. And it became clear to me that something was missing. We were missing something. And I started to ask this very pointed question, because emergency medicine is very much that kind of a field where you can see patterns very, very quickly and very easily. I started to ask patients, what would it take for this to never happen again? And what I learned from asking those issues is, first of all, number one, given any opportunity, that people would not choose suffering. And what I learned was that it was basically boiling down to people having limited resources and having to make these really difficult choices about how they would use their limited resources, making decisions about, do I use my limited resources to pay rent, to try to maintain some form of stable or unstable housing, to feed my family, to pay utilities, or do I use my limited resources for a copay, for a doctor's appointment, or for a prescription, or even for transportation to a doctor's appointment? And for them, the decision was always quite easy, because health and healthcare will always rank secondary to survival. And so the problem there is that doctors are taught to focus on disease, or whatever's sitting in front of you. That's what you're focusing on. So doctors are really chasing disease, patients are chasing life, and the two rarely align. And when they don't align, it results in perpetual cycles of unstable health, perpetual cycles of avoidable ER visits, avoidable hospital admissions, and just, perpetual poor health outcomes. And it's mainly because people do not have the economic resources and financial stability to be able to prioritize health. And so it made me think more and more about, actually, when you think about the data that is coming out now, the ethnic and racial data due to the pandemic right now, that, people of color, Latinx and Black people are really doing worse disproportionately. And when I think about that, I think of how many slides I have seen in my lifetime where no matter what title you put on the slide, demographically, the data will always fall out like that. And you can put anything at the top of it. And so over time, it's made me think more and more about how these things happened and why we have this sort of, these two divergent sort of paths to quality of life for people. And it made me think back to, I think back to actually one decade in particular, the 1930s and FDR's New Deal. And I think at that time, the president was really trying to resuscitate America from, the ravages really of the Great Depression of 1929. And I think one of the things he tried to do was to create pathways to wealth building for people. And one of the most common pathways to wealth building, as you know, in our country is home ownership because of the generational and the familial benefits of home equity. So I thought it was a brilliant plan, except in the exact same decade, he created policies and things that made it so, well, one particular policy was redlining, for example. And if you lived behind red lines anywhere across this country where those lines were drawn, if you lived behind red lines, you actually did not have access to that wealth building pathway. In fact, you were deemed a risk if you lived behind those red lines. And so you didn't have access to the financial services that you would need to get to that home ownership wealth building pathway. And it sort of seems to me at that point, there were two socioeconomic sort of populations created at that time, and it remains fixed to this day. And I guess an example in our city here is the median net wealth gap of $247,000 for whites and $8 for blacks. And so, for people in healthcare, for healthcare providers, it's sort of unacceptable. I mean, where I sit right here in my hospital office, adjacent to many communities of color, the difference in life expectancy between here and a mile and a half up the street is 30 years. And it's really, really hard for us to accept that. So one of the things I think that is required to disrupt something like this is to have a mindset shift about what is actually possible. First of all, understanding why it's happening, and sort of be able to imagine yourself as an actor in this and what you could do different. So I can tell you a little bit of one major mindset shift that we've begun to think about here at my hospital. I mean, we've been thinking about the notion of charity exclusively as an intervention versus equity. And, the thing about charity exclusively is that people will always be in need. They will not be self-sufficient and independent. They won't have what they need to do that. They will always be relying on some sort of a subsidy, versus equity, where people have the ability to achieve at their highest levels and greatest desires. And they have an opportunity to contribute to the larger economy versus depend on it, for subsidies and things like that. And so this whole notion of charity versus equity is something that we've been thinking a lot about. And some examples of how we have looked at shifting how we intervene different. And one example is it's something called determination of need. And in Massachusetts, determination of need means that when you are building onto your hospital, building a new hospital, a new wing or a new floor or whatever, the state says you have to give 5% of the total cost to the community. And I feel like that's the least we could do. But for the first time, when we created a campus redesign recently, we asked the state if we could commit our obligation to various different types of housing projects, various different things. And the state approved it. And so it enabled us to do something unusual for a hospital, and particularly ours, which is a safety net hospital. We would not have that money, in our operating budget or anything, and we could not take that money from anything we had. So we had $6.5 million we had to spend. And so one of the things we did was to invest in a private equity fund that will only fund developments that provide access to affordable housing employment, green walking space, transit, and healthy, affordable food. So it matched our values. And that enabled us to invest in something just a mile from here that is now becoming 323 units of new mixed income housing, some to own, some to rent. And when we went to the ribbon cutting, the most just amazing thing to see was that 70% of the laborers on that contract site, on that construction site, come from the community. The community also wanted a grocery store there. So we did something unusual by, this grocery store was in another city, but again, they match our values. We were able to help that grocery store mitigate the cost of expansion by giving it a no interest loan to come and build the store out in Boston. And the other thing is, we belong to something called the Healthcare Anchor Network, which is a national collaboration of 45 healthcare systems that focus on building more inclusive, sustainable local economies through hospitals being intentional about how they make investments in hiring, how they make everyday decisions in hiring, investment, and procurement. And so, and finally, my last comment is that the Affordable Care Act requires healthcare systems and hospitals to conduct a community health needs assessment with an improvement plan based on the assessment every 3 years. And for the first time ever, the hospitals in Boston conducted one together in 2019. And the improvement plan is based on what the communities told us. And our focus in our improvement plan will be, as directed by the community's responses, are housing, finance and economic mobility, access to services, and behavioral health. And so I hope that sort of frames it in terms of what the root cause is and what our opportunities are, examples of what we could do different to move forward. That's how I see it. And it's all come to me from where I grew up, where I work, talking to patients, which is the most important thing. People will tell you, you just have to ask them. Thank you.
Thank you so much, Dr. James. We'll move to Michelle before moving out to questions.
Terrific. Michelle Corton-Brown, CEO of Quality Interactions. And our company has the privilege of partnering with hospitals and health plans around the country and locally who are focused on improving the experience of diverse patient populations. And in that work, as Thea and Stan have articulated, what is clear is that while there is continuing to be headroom for clinical interactions to be more culturally competent, I think there's broad agreement around that. The issues that face vulnerable populations in our communities go well beyond the clinical interaction. It is exactly what they had just described and what Stan described in terms of income insecurity, housing insecurity, food insecurity. And all of those things conspire to undermine the ability for Black and Brown communities to get some of the health care that they need, to be able to afford prescriptions, to make that difficult choice between paying my rent and paying for a prescription, paying for food and paying for prescriptions, right? So we know this is an issue, not something that's surprising to us, but this pandemic, I think, has created an opportunity for everyone to see in broad relief what this looks like. This isn't the first sort of crisis that we've seen. I'm not gonna go into a great deal of detail, but I think if you look at maternal health outcomes in this country, you'd see the same challenge of women, Black women, Latinx women in this country suffering grave mortality and morbidity rates compared to white populations. So we do have health disparities that we have to address. Quality Interactions has been putting out a great deal of content on this issue. I'd invite you to hit up our website, qualityinteractions.com, look at our blog. We've got a great deal of information about health disparities that if you're interested in more resources, you certainly can access that. I'd like to just maybe take a minute and describe a bit about what the Mayor's COVID Health Inequities Task Force has been up to. We have 3 core areas of focus. One is on testing, And you've heard Stan describe what's happening at his community health center. The city is really proud of the fact that they are funding 8 community health centers and improving testing resources at those centers, and they continue to partner with more. And the idea is really to assure that people don't have to go long distances to get these tests and to be able to access essential care is how I describe community health centers in our neighborhoods. They are really providing essential care. The task force has also been, I think, terrific at accelerating the ability for community health centers to access those tests. And so in addition to the cash resources, they've been able to network among each other and find those resources to get those tests out. Their testing is a huge problem. I think at this point, the mayor's office has told me that about 15,000 people have been tested. That's not nearly enough. And we really have to continue to work on that issue. One of the constraints is that the federal and state levels really control a fair amount of that testing access, but the city of Boston is not standing still. And we are working on ways in which we can enhance and improve the ability to have access. The second pillar of the task force is focused on data. And you can go to the City of Boston website today and see the COVID results by race and ethnicity. And I think it's really important that we be able to have access to that data. It'll become richer over time, particularly as some of the contact tracing data becomes available. We'll be in a space to be able to evaluate and measure our impact because that data exists. And then the third pillar is community mobilization. And we see that manifest itself in a number of ways, including specific outreach to Haitian, Cape Verdean communities, providing patient education to those populations. There's an ongoing effort to expand the work in the Asian community to provide, again, information and resources. The City of Boston has invested in some resources to provide safety kits to essential workers and to communities to improve their safety and health. And in the midst of all of this health focus, we can't really take our eye off of the basic services that are challenged disproportionately in our communities as a result of people being at home. So basic services are being addressed. There are 30 food banks funded by the city that are providing food, mostly focused on youth, but most recently 6 of those sites are now providing food to adults as well, Monday through Friday, with some additional support on the weekend. So just wanted to give you a sense of what the city is doing. They are looking for companies to collaborate with them. Shameless plug to Stan, you know, if companies are thinking about their investments, philanthropic investments, community health centers have always been here serving the needs of community. And to the extent that, you know, your wallet allows you to invest in their work, a powerful way to do that. The other way in which, you know, businesses can think about doing some of this work, and I'm not going to spend a lot more time on this, I think I'd like everyone to be able to share in this conversation, is around how you lift up and support the essential workers within your own organizations and really empower them to tell you what they need. Because they can share that. But there's no surprise that the hotspots in our city are the places where people are often paid the least, where they're in essential worker jobs, where there's population density, where there are intergenerational families living together, where the notion of self-isolation is mind-boggling. You know, there isn't really space to do that in small spaces where people are literally living on top of one another. And where a number of those folks in those communities have to get up every day and go to work and stock our shelves and take care of our seniors and do other essential work. So I'm going to stop there. Thank you.
Thank you, each of you, so much. I mean, I think you covered such a range, and I appreciate all of you for the strong work that you're doing through your agency and even on your own personal commitment. So thank you so much for highlighting some of the root causes that we know existed way before COVID-19. So I actually want to uplift one or two remarks that I heard from each of you. And of course, we're hosting this conversation through the Boston Chamber. So I want to make sure that we're speaking directly to our members here. But what can you help us and share why this conversation is relevant and important to the business community? What can we as leaders in different spaces do to understand these health disparities, but why it really affects the economy at large? Can you share a little bit more about that?
You want me to go? I guess for me, and I think I made it in my comments, I made the comment of try to reimagine yourself in kind of the new reality. And, I hate to say it this way, but use this crisis or devastation that's happening as a catalyst for change. Don't go back to business as usual. For example, I'll give you an example of us. Prior to COVID-19, we were in the midst of a capital campaign. We are in need of building a new health center. We received designation from the city for a plot of land. And, but what we wanted to do is to be more impactful. So we developed a shared vision with the community. We actually went out into the community, got their voice, and figured out that we could be more impactful by not only getting our health center and leveraging technology to deliver more efficient care, but that we could also on a lot that we owned and the lot that the city is providing, get involved in economic development and revitalize an area that really needs to be revitalized. We viewed ourselves not only as an entity that improved access to care, but actually looked at ourselves as an economic anchor for that area. We provide jobs in the community. About 70% of the people that we hire come from the community. So we looked at this as an opportunity to not only build our health center, but actually get into building affordable housing. And we have a building that we want to, that we currently occupy that used to be a car dealership that we want to convert to affordable mixed use facility that has affordable housing and economic space or commercial space on the bottom floor that would bring more investment into the community. So we went from just looking at trying to build a health center, which would have been easier for us to probably do, to now this situation where we're reimagining ourselves as entity that's going to lead the economic revitalization of a particular area. So I would invite companies to try to think of, as they think about the future and future planning, to be a little bit more innovative in your thought process and see how you can bring other people, others along, or make sure that you create advantages for the surrounding community. Thea put it eloquently when she said the idea of creating situations where there can be upward mobility. And so basically with our project, we're looking to be able to do that for the community at large. So we're increasing access to care, providing a bunch of construction jobs. We've partnered in the community to figure out what kind of resources need to be there. Affordable housing is going to be there. We're hoping to make sure that there's some businesses that'll take one of the floors, and there'll be synergy created between not only the buildings, but synergy created in the neighborhood, and hopefully synergy would lead to additional resources in that area that would revitalize that particular area. Because like I said originally, we serve some of the more economically disadvantaged zip codes in Boston. So that's kind of one way in which business communities can start to imagine themselves in the solution.
I have a few questions coming in from the audience. Thank you, Stan, so much for placing an effort on the business community as a focus. Now I'm getting questions from the audience. This is from Pablo, and he wants to ask Dr. James and Michelle Corton-Brown, can you talk more about the task force? How was it formed and who else serves on it? Are there representatives from communities of color on the task force? Question from the audience.
Michelle, did you want to go first? Or you
Sure.
want to go answer that question?
Sure. The task force is 24 members strong. It is largely comprised of African American and Latinx leaders working in hospitals, health plans, business leaders, and community leaders on this group. So it is a broad representation of our city. I can lift up a couple of names that may be familiar to you. My colleague, Dr. Joe Bentoncourt at MGH, serves on the task force. The pastors, Gloria and Ray Hammond, who many of you may know, are not only religious leaders at Bethel AME, but they are also physicians as well. There are a number of people like Michael Curry, the Mass League of Community Health Centers. Just trying to go through the list quickly. Thea's on the committee, and her representation, I think, is really very powerful. But this is a broad group of Boston being represented on this committee.
Dr. James, any thoughts that you want to add on the Healthcare Inequities Task Force?
The only other thing I want to say is it is a very active and fast-moving task force. It has let no grass grow under its feet at all. It just came out of the gate running 100 miles an hour, and it's a wonderful group of and a wonderful collaborative effort. They've done things right away, so it's been great.
Thank you so much for sharing that. Here's another question coming in. This is from Abigail. She's asking, how are Boston healthcare providers taking into account the language preferences of patients? We know that many resources are not available in different languages, and they're wondering, are interpreters being deployed? What are you seeing on the ground in terms of language access?
So I would say quickly, in terms of the mayor's task force, one of the things that we've been able to do, and people in the committee have been able to organize, is reaching out to communities, different ethnic, racial communities based on language. And it was brought to us very, very early that not only English being a barrier, but also how the words even translate, the concepts translate in other languages. For example, social distancing versus physical distancing, for example. But anyway, we've had, webinars, conversations with these communities. And I know for the Haitian community webinar, we had an infectious disease physician here from our hospital, from Boston Medical Center, who actually was on the call. And also the entire webinar was interpreted. So there was someone there to interpret it from language. The other thing I'll just say quickly for anyone, given that the question was about Boston, you can Google or you can put in your browser massthrive.org, and any language you can imagine will come up. You put in your zip code, you put in what you're looking for, the language you speak, and it'll come up in that language, massthrive.org.
Can I just add that community health centers, for example, are grassroots entities. Many of them are in vulnerable communities and have had a history of dealing with clientele that speak various languages. If you come in my health center, for example, the people that are there reflect the people that are in the community. So even if something is not available, we can always try to find somebody that's employed by our agency that'll be able to help out in making sure that we can communicate with patients that are walking through the door.
Thank you, each of you. Here's another one that's coming in. Mattapan and Hyde Park have both been highlighted as neighborhoods in Boston that are seeing heavy levels and have emerged as hotspots. So the question from the audience is, why do you think these two particular neighborhoods, Mattapan and Hyde Park, both which have a pretty high Black and brown people of color and immigrants in both of those areas, what are you thinking are some of the reasons why these have emerged as hotspots? Dr. James, I think you're trying to speak, but you are muted.
Thank you. I'm sorry about that. I think one of the reasons is many people who live in those areas, there are people in those areas who work in jobs that are considered essential workers. And I think that these jobs are people facing. They may not necessarily provide the sort of protection that people need. Also, they aren't the kind of jobs where people can have the luxury of working from home. And so, and then also, maybe, populations where there are many family members, living in a small space and finding it extremely difficult, if not impossible, to practice physical distancing. And so I think all of those kinds of, those particular circumstances might be the cause of them being disproportionately represented in the data.
Anyone else? Michelle, Stan, do you want to add any thoughts about why these two neighborhoods have emerged as hotspots?
The only thing I would add is population density is a real issue.
Yeah, I mean, I'd agree. I mean, I'm an immigrant, and when you have immigrant populations, a lot of times there are more folks in the home, more folks sharing an apartment or whatever, and you have tight spaces, and it's very hard to do social distancing. Many of them do jobs like CNAs, and they're usually low-paying jobs, but they're required to show up, and they're taking public transportation. So all those play a part, in my opinion. And yeah, I think those are the biggest pieces.
Now we're getting near the end, and I just want to make sure that we give some time to talk about some solutions. So each of you shared how what we're seeing now is nothing new, at least from the lens of thinking about the social determinants of health, how housing, many of you have brought that up, which makes me really happy. The need for affordable housing in our city continues to be a public health crisis on its own as well. Do you see potential for a large-scale response to address equitable health and economic recovery after COVID-19? I know all of you are working in an area that is not only hard hit, but maybe perhaps there have been some time for reflection and thinking about what can we do together to ensure that we're thinking about short and long-term goals that will get us to an equitable outcome. I'm looking forward to hearing some of your thoughts on that. I'll start with you, Dr. James.
I think there's definitely an opportunity for, in a widespread collaborative effort. Hospitals, for example, can't do this work alone. And I've always been, saying that it requires innovative business models and collaboration among hospitals and business people, foundations, philanthropy, and government, as well as the communities. The community and community-based organizations. So it requires a collaborative effort. I also feel like we don't have to just give out help, support, financial support, just throwing it out there, because you can't measure what you're not collecting and monitoring. So I feel like it's a relatively not difficult and complicated process. I feel like you use analytics to help you identify where the opportunities are. You choose what opportunities you're going to focus on and how and where you see yourself, your organization in that space. And then you monitor that in a dynamic way, monitor the data and have as your outcome something that will have a measurable impact on quality of life trajectory. For example, not just to fill a gap someone has at that time, but to make it sure that that person has a different socioeconomic status at the end. That would be your goal. And I feel like if we make those kind of like concerted efforts that's, you know, analytic, data driven with a very specific outcome that you are aiming for, and work together to use all those different entities working together, I think it's entirely possible. And, you know, Boston is a world-class city. You know, it's a city known for, you know, innovation and solving problems. And just imagine just how many more, just how much better it could be, you know, having different voices, more voices at the table in doing these things, and also aiming for something that is that has more of a societal impact, as well as a business impact and an undeniable return on that investment.
I guess I would add that I think there could be initiatives that come out of this. I mean, look at the Mayor's Task Force for one. I think it's important that these initiatives have a community voice. And the reason I say that is so that it can continue, it can maintain sustainability, and it could garner trust. Michelle and I was speaking about how to create messaging that doesn't rely on some new issue to pop up for it to be consistent. In other words, maintain a messaging that's trusted out there in the community, so that we're not addressing issues episodically. We're currently in a crisis, so you know we're developing messaging for that. But once a crisis passes, we need to kind of maintain that. And so I think with a community voice as part of whatever initiative happens, I think that's extremely important. I do believe, however, that we do need to do a significant amount of community development. And I think though the community developments, we need to be thinking about it as we think about analytics. We also need to think about how the developments we put forth impact social determinants of health. For example, does it improve health status? Does it improve housing for folks? Does it improve education? Does it create jobs, jobs that are career jobs? That also looks at the environment, because you know, the environment and how it's treated has an impact on us. So if I were to add, those are the two areas that I would add.
And I would just add, maybe as the last word on this, that if we don't use this pandemic as an opportunity to really disrupt, it will be a true shame. You know, Massachusetts has the distinction today of having the third largest number of COVID positives and deaths. We're a world-class city. We're a city of solution makers. And we have this opportunity to get to some of the root causes here and make a transformative difference in our society. And I believe that we've got the know-how, the resources, the skills, the expertise to make this shift happen. But it's going to happen on the other side of this pandemic. Let us hope that the root cause here of the illumination of this kind of death rate, this kind of suffering, allows us to be thinking more in an intermediate and long-term basis about how we develop the dashboard that they had just described to really move the needle and make change. It's possible, we can do this, but it's going to require a sustained effort. I know that the City of Boston is quite interested in collaboration, a public-private collaboration in the future around how we get to some of these root problems and deal with some of the comorbidity issues, some of the highest incidences of diabetes and heart disease and asthma that we have in our community. So I'm hoping that this is the beginning of a conversation with the business community, and that we will all be focused on how we can move the needle in the future.
Thank you so much, Michelle, for taking a positive tone there as we close up. Thank you so much for highlighting all of these important efforts and really giving us something to think about as we go throughout our week today, making sure that we're rooted in the reality. I like Stan's comments in the beginning saying that this is a we disease. So we know the Black and Brown community is being hit the hardest, but we can't turn our eyes away. We want to make sure that we're moving towards solutions that are equitable and that look towards recovery from a new lens. So thank you so much to each of you, Dr. James, thank you, Stan, thank you, Michelle, for all of your thoughts and sharing your insights with us. Thank you for the heroic effort that each of your agencies are doing and playing a part in keeping us safe and healthy as we navigate this new reality. Before we close, I want to highlight our COVID-19 business resource page. You can learn more about federal, state, and local updates regarding the coronavirus, as well as upcoming virtual conversations like this one at bostonchamber.com. As Michelle said, we hope that this is only the start of a conversation. We acknowledge that 1 hour is not nearly enough, but we invite you to stay tuned for more from Economic Opportunity, and we welcome any remarks and input from our audience as you tuned in today. I'm also thrilled to announce that we have our 2020 Small Business of the Year Award nominations. They're open, and we invite you to nominate or even think about applying for the 2020 Small Business of the Year Awards. The nominations will run through this Friday, April 24th, and you can register online by visiting bostonchamber.com. Thank you so much to each of you for joining us. Please stay safe, please stay healthy, and let's continue fighting the good fight. Thank you so much. Have a great night.
Thank you.
Thank you. Thank you so much for everything.